Hello and welcome to part 3 of the session on congestive heart failure. We have so far seen that what is the strategy of management of congestive heart failure, which are the key drugs used to manage congestive heart failure as chronic management as well as in acute episodes. And now we will go on to studying the individual actions of drugs starting with digoxin. Digoxin was in fact the first drug which was available to treat this condition called congestive heart failure. Dropsy as it was called then. Dropsy after the major symptom seen in these patients, that is edema and swelling of soft tissues. Subsequently, the pathophysiology of this condition which responded to digoxin was understood, and this edema or swelling was known to be because of congestion, backlog created due to reduced pumping power of the heart. And the condition now we know of as congestive heart failure. So let's see how this digoxin helps a patient of congestive heart failure. We have already identified its place in the management strategy. Congestive heart failure is associated or is due to reduced force of contraction, and digoxin and also dobutamine are the two drugs which help us to improve the force of contraction. They are the selective positive inotropic agents. There are many other drugs which could also improve the force of contraction. For example, adrenaline and norepinephrine. Can we also use them in this condition? Definitely not, because they do not help us to selectively increase the force. They also cause tachycardia, which is increasing cardiac work, and they increase the preload as well as afterload through their vascular effects. So what we need here is a selective positive inotropic agent, and that is what digoxin is. Chemically, digoxin is a cardiac glycoside. Glycoside tells us about the chemical structure, which improves the myocardial efficiency. What do you understand by improved efficiency? If we were to talk about motorcycles, the motorcycle which gives greater mileage for the same fuel consumption would be considered as more efficient. Similarly, myocardial efficiency is how much cardiac output we get for a given amount of oxygen consumption. And digoxin enables the heart to give more cardiac output without increasing oxygen consumption, because it is doing this by increasing the force without increasing the heart rate. Increase in heart rate would directly lead to increase in work and increase oxygen requirement. So selective positive inotropic agent digoxin. In fact, this is the only selective positive inotropic agent with negative chronotropic action. That means it not only does not increase the heart rate, it causes reduction in heart rate with its own benefit for a patient of congestive heart failure. How does it manage to do it? So at cellular level, digoxin interacts with an enzyme called sodium-potassium ATPase. This enzyme is actually working as a pump, exchanging sodium for potassium, throwing sodium out and taking potassium back into the cell. In what way is this pump related with the effect we get with digoxin in the myocardium? For understanding this, we need to delve a little into our knowledge of cardiac electrophysiology or cellular electrophysiology in general, because this is to do with action potential. Most of you would be aware that action potential is the way of generation of impulses, conduction of impulses, and getting these excitable tissues to do their job. And action potential is nothing but rhythmic ionic movements across the cell membrane. At rest, we say the cell membrane has got more negative charge inside as compared to outside. So that generates a membrane potential being minus 90 millivolts inside the cell. The difference is minus 90 millivolts. When the tissue is excited, there is generation of action potential, and the first part, the zero phase of action potential, involves influx of sodium. And this influx of sodium would reduce the negativity inside the cell because positive charge is coming in, and thus the membrane potential starts reducing and may even go to the positive side. This process is called depolarization, abolition of the difference in charges across the two sides of the membrane. And sodium is responsible for this in most tissues, including the myocardium. Once zero phase is completed, the process of repolarization starts, that is, restoring the negativity inside the cell. And for this, potassium ions, which are more inside the cell, start leaving the cell and going out. Therefore, we see this phase 1, where the membrane potential is again moving towards negative. The process of repolarization has started. In between, we have a plateau phase, because during this phase, positive charge is going in as well as equal amount of positive charge is going out. So there is no difference in the membrane potential. It is remaining stable for a while. Once calcium entry stops, again the membrane potential will start becoming more and more negative because calcium entry stops, but potassium keeps going out. What decides this direction of movement of ions? Ions are not lipid soluble, so they are not diffusible, but they can cross the membrane once the special channels meant for them are opened. And what would be the direction then? Once the channels are open, the direction is along the concentration gradient. So why does sodium and calcium go into the cell when the channel is open, whereas potassium goes out when the channels are open? That is because sodium and calcium are predominantly extracellular cations, whereas potassium is predominantly intracellular. So when the channels open, they move in the other direction. How many times is this happening? For example, in our heart, that sodium is going in, calcium is going in, and potassium is going out as a part of this action potential pattern. This happens at least 72 times per minute, even during rest, because that's our heart rate on an average. And if this keeps on happening, sodium keeps on going in, calcium keeps on coming in, and potassium keeps on going out, can potassium remain predominantly intracellularly? This is made to happen by actively putting these ions back into their place during phase 4. So during phase 4, the resting phase, where there is no change in the electrical potential, these ions are put back into their place by an active mechanism involving enzymatic action. So sodium-potassium ATPase we are talking about is actually the enzyme which is responsible for exchanging sodium and potassium during this phase 4. So it is putting potassium back into the cell and throwing sodium out. Parallelly, there is another mechanism also working. Since calcium has also come in, it has to be thrown out. And to maintain the isoelectricity, to maintain the stable membrane potential, it has to be exchanged with some cation. So this second exchange which keeps on happening during phase 4 is again sodium-calcium exchange. Digoxin interacts with and inhibits the action of sodium-potassium ATPase. And therefore, it inhibits or prevents the throwing out of sodium for taking in potassium. And because this sodium is not getting thrown out, the second mechanism, which is supposed to take in sodium in exchange for throwing out calcium, that cannot function. So indirectly, digoxin is also preventing the second exchange, that is throwing out of calcium and taking in of sodium. The end result is more calcium remains inside the cell. And as you know, calcium is required for contraction. So because there is more calcium inside the cells, because directly sodium-potassium exchange has been hampered, but indirectly sodium-calcium exchange has also been hampered, and myocytes end up with having more calcium inside the cells. And this more calcium made available helps to increase the force of contraction, helps to increase the cardiac output without increasing the heart rate. So that explains us why digoxin allows the heart to beat stronger without increasing the oxygen requirement. Let's see the secondary benefits of this basic action of digoxin. Basic action: more calcium inside the cells, more force of contraction, and more speed of each contraction. Not greater heart rate, but every systole is stronger and shorter. There is a clinical implication to shortening of the systole as well. We'll see it subsequently. So because the systole becomes short and powerful, cardiac output increases. And that was the basic problem of the tissue. Reduced force of contraction, reduced cardiac output. So that is getting taken care of. Short, powerful systole improves cardiac output. And what are the secondary benefits? Earlier, because the output was decreased, but the compensatory mechanism was putting back more blood, end diastolic volume was going on increasing, and larger the fiber ring at the end of diastole, greater is the energy required for contraction. So, increased end diastolic volume was increasing the energy required for contraction. Because output improves, end diastolic volume will start going back to normal. Second benefit is the compensatory mechanisms activated because cardiac output had dropped, that will start settling down. So both these actions are reducing the oxygen requirement, reducing the cardiac workload. Another important action reducing the workload is reduced heart rate, which happens because of vagal stimulation by digoxin and also because the compensatory mechanism, importantly sympathetic overactivity, has settled down. And all of these actions are going to reduce the workload, reduce the oxygen requirement. What is the significance of shortening of systole? You know there's something called cardiac cycle time with a very short period for systole and a larger period for diastole. Diastole is the period when heart gets its own blood supply. So diastole is the rest time and it is also the period for perfusion of the myocardium. If there is no change in the heart rate, but the systole is shorter, diastole will become longer. So the resting time and the perfusion time for the myocardium is increased. What if the heart rate is reduced? If heart rate is reduced, each cardiac cycle gets more time. So prolonged cardiac cycle with narrowed systole gives a significant increase in diastolic period and perfusion period. And therefore, there is significantly increased oxygen supply to the myocardium. So you can see that digoxin increases the force of contraction while reducing the oxygen requirement and improving the oxygen supply to the myocardium. So these are the beneficial effects of digoxin in congestive heart failure. If you've understood this mechanism, like to share this video with others, you're most welcome. We'll stop here and see the rest of the actions of digoxin, good and bad, and the precautions to be taken in the next part. Thank you.